not only just virgin slack wrist and snack wrist that this is going to be helpful for, but it's also takedown of prior wrist fusions,
Right. Yeah.
especially when we get the lunate fossa
Right.
approved.
Yeah. Yeah, we're pushing hard on that. They're doing the testing now, and we're going to resubmit. So, the goal is to try and get that approved as soon as we can. The other thing too is, and I don't know, you and I haven't chatted in a couple of weeks, but we just launched a bone product for the shoulder to do a ladder J. So
Uh-huh.
instead of having to take down the coracoid, it's a pre-shaped piece of bone that's got the two drill holes for the screws and then suture holes, already drilled. And
Right.
it's already the shape of the glenoid. And then we give you a kit so that you prep the glenoid. So when you put the piece of bone on, it matches perfectly.
Wow.
And so we've been doing a lot of work in bone. And now we've created a hubcap made out of bone for four-corner fusions.
Wow.
So that way, at least you can get bone to grow, right? So
Right.
down the road, if you have to revise it, you got more bone to play with because you put bone in instead of a piece of PEEK or a piece of metal.
Wow, that's a great idea.
Yeah. So that's the goal there is to get that to launch that in August.
I also think that there's a real role for this elsewhere in the wrist and hand.
Yeah.
The ulna is easy. I've done a couple cadavers. I've actually used the same implant as the capitate.
Right.
It's very easy.
Yeah. Well, this is just between you and I, but we also got approval this week or last week for a base cap for the phalangeal side
Yeah.
in the toe. So it's the same idea of the screw, right? But
Yep.
onto the screw goes a metal concave implant.
Wow.
I'm sure you don't have to think very far about where you might be able to use that in
Oh,
other
yeah,
places.
God. All over the place.
Right.
Yeah, all over the place. That'll be a
Yeah.
lot of fun.
Yeah. All right. So they're starting to come on. I mean, we're a little bit early. Are you at home?
But no, I just got finished in my office, so I just ran in here and um,
Okay.
ready to go.
Good. So my daughter got into Drexel,
Oh, excellent.
so that's where she's going.
It's Drexel has a real hand on um, the workplace and getting involved early,
Yeah, that's what
and
she's
the
doing.
nuts and bolts,
Yeah.
which I think is a great idea.
Yeah. Yeah, exactly. I mean, that's why she wanted to get in there. That was her first choice, was to get into the co-op, which she did.
That's
So,
fantastic.
so she's pretty excited.
She's following Dad's footsteps.
She is. She's, even though I never did a business course in my life, but yeah, I mean, definitely.
You learned it the hard way.
Yeah. Well, my degree's in clinical psych.
Really?
Yeah.
I didn't know
I was
that.
going to be, I was actually doing my PhD in clinical psychology, but there was just no way I could spend 5 years in the lab, doing lab work. So I said, I'm out, you know.
That's a great way to go.
Yeah. So, but the numbers are starting to creep up now. So yeah, we should be good. I think we should have somewhere in the neighborhood of 40 people,
Oh,
today
good. Oh, that'll be fun.
online. Yeah. And who did I see? Oh, you know who I saw this weekend? Do you
Who?
know Roosh down at
Yeah, Dave
Duke?
Roosh. Yeah.
Yeah. Yeah, I was at the Duke hand meeting on Friday and Saturday.
Dave's a really good guy. We've been contemplating trying to recruit him to come to Philly.
Really?
Yeah.
Yeah, he was pretty excited. I think he's going to get started with the wrist, and then he has some other ideas. When he saw the bone thing, he got pretty excited about applications for that as well in the other extremities.
Yeah, there's a lot of stuff you can do with that.
Yeah, yeah, he's a good guy.
Yeah, I like Dave.
Yeah, I saw him, and I saw Moore and Hawker. and a bunch
Yeah.
of the other Duke guys.
Oh, that's great.
Yeah. All right. Well, let's see.
I was in Honduras last week on a medical mission.
Really?
Yeah, we did about 150 surgeries in a week.
Wow.
We were beat.
That's unbelievable.
They're so poor, you just can't imagine. They
Yeah.
have nothing.
Yeah. What did you do? Just all, I mean, the hand, elbow, or?
Yeah, all hand and elbow, and they have a real machete problem down there, a social problem, and people have defensive wounds for machete tendons,
Right.
nerves. It's just really a horrendous problem.
Wow.
A lot of congenital stuff too.
Huh. Well, I know another distributor of mine. He was down in the Dominican doing
Yep,
total joints last week.
yep.
You know, same thing.
Yeah, there's a real need, and they told me that let me see, more than half of Hondurans live on less than $1 a day.
Wow.
Because they asked me what you can get for $1 in Philly. I was like, maybe a soft pretzel.
You probably couldn't even get a coffee for $1.
I don't think so, not anymore.
No.
It's pretty impressive.
Yeah. Yeah. My wife just came back from Costa Rica, and she said the same thing down there. You know, beautiful, but a lot of poverty.
Yeah, yeah. There's poverty that's hardly understandable when you think about poverty in the U.S. It's just no comparison.
Yeah. Yeah. Oh, absolutely. All right, we're almost there. What else? Yeah, so what's the next hand meeting you're going to? Is it the one in Austin?
Probably, yeah. Yeah, I'm gonna be in London in September.
In England?
Yeah, London, England for 3 or 4 days, and I got a call from a guy in London who wants me to give a talk. I haven't decided whether I'm going to do it or not. I'm also going to be up in Scotland.
Well, that's cool.
Yeah, then
Cool.
I get invited. I'm going to be supposed to be in Norway later on in the year, and yeah, it's just a matter of trying to pick and choose.
Right. Well, I mean, London's never a terrible place to go. There's always good stuff. September is
Yeah,
actually a good month.
I would think so.
Yeah. Well, let's see. We're at 29, so get one more user, and then I think we'll, you know, I'll just check with some of the guys to see if they can hear me or hear you.
Okay. Okay.
Yeah, Patrick said we're good. Okay. Yeah, Justin. Yeah, they're all saying it's good. Okay.
So just tell me when you want me to get started, and I'll get rolling.
Okay. All right. Well, let's just give it, one more minute, and then we'll have you
Okay.
start.
Okay.
Now, you've been to London before, right?
No, I've never been to London.
Really?
I've landed there and then taken off right away. It's only
Oh
as
no,
a sort
Randy,
of
you
a
got to go to London. There's
yeah.
so
I'm gonna
much to
get
do.
yeah. I've heard good things about London.
It's such a cool place. Yeah. Like if you want to go see plays, if you want to go see live bands, I mean, it's awesome.
Yeah, that sounds like fun.
All right. We're at 30, so let's give it a shot. So I'll do just a quick introduction,
Okay.
um, and then we'll take it from there. So
Excellent.
thank you everybody for joining us. We're going to get started. There's probably a few other people coming on, but that's okay. If you have any questions, just type those in the question section. I've opened the chat section as well, just in case you guys, don't know how to use the question section. And then I'll read those off to Dr. Culp as we go through the presentation, and we'll just decide when the best time is to ask the question. All right. So just a quick introduction on Dr. Culp. I mean, most of you know him. He's a nationally acclaimed speaker, obviously a developer and a long-time educator for hand and elbow surgery. He's at the Philly Hand Center. He holds the Philly Hand Meeting each year, which is extremely well attended by all the top guys. So without going into any further detail, I'll hand it off to Dr. Culp, and he can take it from there.
Thank you, Lester. I'd like to thank all the attendees for taking time out of your schedules to listen to what I think is going to be a real game changer in implant usage in the wrist, and it's called Arthrosurface WristMotion. And you can see an X-ray here in front of you. There's an implant in the capitate, and I think that you'll see that it's sitting in the lunate fossa. I'm going to go into more detail at this point. Lester, I'm getting something that says screen sharing is now paused.
Not sure why that is. Is that just
let's move this away. It says move this away. I can't do it. Oh, anyway, there are three of us that have been involved in looking at this design. Dr. Insuk Yi out of New Mexico, Cheryl in Alabama, and myself, and really excited about it, and I hope you are too. So let's go into some of the details. As you know, wrist anatomy is complex. The bones are connected by ligaments, which allow smooth, free motion in multiple planes. There is no muscle attachments directly to the bones of the wrist, and therefore they're controlled by muscles and tendons that cross them and the ligaments that connect them. Wrist arthritis, therefore, was seen in post-traumatic issues, as you see here, where the scapholunate ligament is disrupted. We're all familiar with rheumatoid changes in the wrist, osteoarthritis, disease states such as Kienbach's AVN of the lunate and Pricer's AVN of the scaphoid, and increasingly recognized as metabolic problems with gout and pseudo-gout that I'm seeing more and more commonly now that I'm looking for it, producing the majority of the arthritic conditions that we see, which are called slack and snack wrists.
Right. Hey, Dr. Culp.
Yes.
If you just hit the play button, you should be able to move the screen.
So hit the play button. Let's see, where would I put that? This is pause version. Would it be the green?
I can see the first. I can see the first one, but I think you've already gone through a couple of others, and they haven't shown.
Another one at the top of your shared screen. Please move this window.
It's under screen sharing. Yeah, it's
How about now? How about now? Is that better?
No, I see the presentation, the invitation, but not the actual PowerPoint.
How about now?
Yes. Now I see it.
Okay. And how about now?
Yes. Yes. Now we're good.
Okay. Well, now we're good.
Okay.
Should I go backwards or should I start again?
No, I think you can just take it from there. You were only on one slide.
Okay.
Yeah.
So when we look at treatment of wrist arthritis, we're all familiar with the variety of options surgically. Proximal carpectomy, partial wrist fusion, and the most commonly performed is a so-called slack wrist procedure or four-corner fusion. Total wrist fusions and wrist arthroplasty in a variety of flavors, including total wrist arthroplasty, hemiarthroplasty, and what we're going to present today, which is a capitate resurfacing arthroplasty. Total wrist arthroplasty was originally described by a German and Austrian surgeon, Mr. Gluck, in 1890, who implanted an ivory device in a wrist to salvage a tuberculosis problem in a patient. This was progressed, if you will, by Al Swanson, who developed a silicone implant very similar to the one he had for MP and PIP joints. It has lost favor in some ways because of silicone implant problems due to synovitis and particulate problems. Others tried to take some ideas from the hip and move them into the wrist. Muley and Volts. Some of the problems with them included range of motion activities and center of motion, which were not appropriate for the wrist. They were not located exactly in the center of the capitate. Some of the prongs, if you will, did not have the correct metal and ingrowth activity, so that there was problems in that there was good early pain relief, but loosening was a problem. One of the issues is that was looked at and seen very, very early is that the carpus and even the metacarpals are not nearly as stout as those of the hip and knee, and therefore we were seeing distal loosening very early. Bob Beckenbaugh at the Mayo looked at the biaxial design, where there was an implant cemented to the long metacarpal. One of the issues there was that there was loosening of the stem in the long metacarpal due to the differences in the moment arm, meaning that the long metacarpal had a very long moment arm, whereas the stem had a very short one, and therefore the pressures on those areas were enormous, leading to loosening and fairly frequent stem erosion through the metacarpal dorsum. More recently, due largely to the work of Brian Adams, universal motion design has been looked at. It's a modern version of a ball and socket joint where there was better fixation in the carpus and the metacarpals, an ellipsoid type design onto the radius. Not true ball and socket, but a different version. Initial results were excellent up to about 7 years. Still not recommended for really young active patients due to complications of loosening and even dislocation. One of the problems that was seen in more recent studies is that about half of the patients at 10 years had carpal-sided loosening. Despite excellent surgeons and using excellent technique, and that became an issue, carpal loosening at 10 years. So the limitations in the current group of arthroplasty is that, number one, large bone resection makes future reconstruction difficult because there's not much bone left after a total implant is placed. Motion was about 50% of normal despite our best attempts to get better motion. We were never really able to recreate the valuable dart thrower's motion because of the design of the ellipsoid total wrist implants. And then finally, as I suggested earlier, long-term durability. At 10 years, about half of the carpal sides were loose. The other popular procedure is something called a four-corner fusion. It's probably the most popular motion-sparing procedure at this time, where the arthritic scaphoid is excised and removed. The remaining carpal bones are fused based on the fact that the radiolunate joint is largely spared of the arthritic condition in the more common slack and snack wrist issues. It is technically more difficult. A variety of implants have been looked at, including pin screws, hubcap round designs with screws. And one of the issues with it, and you can see an example here of a fairly bad slack wrist, where the capitate is involved, is that there is a fairly high disappointing rate of non-union. If you look at this study by Bain out of Australia, that about 5% of them went on to a non-union despite good technique. They can develop osteoarthritis, even though it's about a third of the rate of approximal carpectomy. They can develop osteoarthritis at the radiolunate joint. Any procedure in the wrist can develop CRPS at about 1% in his study. Infections were about the same as PRC. dorsal impingement is an issue if you do not correct the DC deformity that is noted for most slack and snack wrists, meaning that the lunate is tilted dorsally so that the capitate then impinges on the dorsal radius at a rate of about 2.6%. And that becomes a very difficult issue in terms of treatment, whether you take down the fusion or remove some of the dorsal radius. There were hardware problems in about 3% of cases. Some screw breakage has been an issue. And then conversion to a total wrist fusion was very similar to that of proximal carpectomy. Proximal carpectomy has been a very popular procedure for the common arthritic conditions in the wrist. It simply means that the arthritic bones of the proximal row are removed, and the articulation between the capitate and the lunate fossa of the radius is relied upon to preserve the joint. Good 5 to 10-year results are noted. 50 to 70% of normal wrist motion is usually seen. The problem with most recent studies, including one recently out of the Mayo Clinic, is that patients in about 35 to 40-year age range were wearing out the radio capitate joint. And so that it's somewhat less popular now with patients that are under 35 or 40 to perform a proximal carpectomy. The four-quadrant fusion is probably more popular in that age group, and the PRC may be becoming more popular in the more older age group. Here's an example of a patient with a obvious scapholunate association with early radioscapha articulation, no involvement of the capitate, which would essentially preclude use of a PRC in some ways. And then you'll see postoperatively here with a relatively well-maintained radiocapitate cartilage surface immediately postoperatively. But then when you go to 3 months, you'll see that there's a decrease in the radiocapitate joint space, not necessarily associated with symptoms, but still worrisome. And then at 7 months, you actually start to see sclerosis, which is a progression of the arthritic condition at the radiocapitate joint, which does become worrisome because that means that the surrounding bone surfaces are now responding to the loss of cartilage. If you look at 10 years, many of the patients that are younger have this kind of an arthritic picture radiographically, where there's essentially no joint left. And this is now associated with symptoms as described by Joan Brigley in Pittsburgh and others. The problems with the proximal row carpectomy are the following. The capitate shape is not the same as the lunate fossa of the radius. There's sometimes poor capitate cartilage, particularly with the more advanced stages of slack and snack wrists, so that some of them have no cartilage whatsoever on the proximal capitate, or at least on the ulnar side of the capitate. There's an inherent mismatch between the shape of the capitate and the lunate fossa, and when this occurs, biomechanically, it leads to increases stress on the cartilage of the capitate and the lunate fossa of the radius, which we know will eventually lead to arthritic changes. Now, the prosthesis that we are talking about currently tonight is called the Arthrosurface PRC Plus. The reason that it has some benefits is that it has a better fit with the lunate fossa. Like we know, as described earlier, that the capitate is not the same as the lunate fossa of the radius on the lateral view, only 57%. And the AP view, only 7% seems to articulate correctly in terms of size. It allows for increasing carpal height over proximal carpectomy. One of the issues that inherently is asked about a proximal carpectomy is what happens to the ligaments of the wrist when you lose the articular height and bony height, and what happens to the tendons that cross the wrist joint when you lose carpal height. Well, what happens is that the soft tissues, whether it be ligament or tendon, become relatively longer, and therefore this leads to issues of weakness of grasp and tendon use. This Arthrosurface PRC Plus resurfaces the arthritic capitate and provides more normal fit to the lunate fossa and the carpal height. So here's an example of what an Arthrosurface hemicapitate looks like. You'll notice that the carpal height is more appropriate for the capitolunate joint. The hemicapitate essentially acts like a lunate. And surgically, the lunate fossa can be measured, that there's several different radiuses of curvature, both in the coronal and sagittal plane, and several different sizes that lead to a more exact fit of the Arthrosurface hemicapitate to the lunate fossa and to the carpal height. Now, indications for use, official indications for use as a partial replacement of the wrist joint, and this is FDA approved, so this is nothing you have to tell your patients that is secret or unapproved. It's approved by the FDA. Non-inflammatory degenerative joint diseases, including osteoarthritis, traumatic arthritis, and AVN, and I think that's the most common use that I've had for it, and I've been very, very happy with it. Rheumatoid arthritis, probably less so, but still indicated. Revisions where other devices and treatments have failed. For example, I have used this and failed slack wrist procedures. Even ones that have been successfully fused, the patients are unhappy with their motion, which often is 30% with these procedures. I have taken them down with excellent results and happy patients because of more wrist motion. Sometimes traumatic issues in the carpal bones, whether it be perilunates, can be better treated particularly with chronic perilunates and missed perilunates can be better treated with this procedure than others. It tended to be used as a single implant. It is made out of a titanium alloy fixation screw and has cobalt chrome modular resurfacing cap that are both connected via Morse taper. It is exceedingly easy to put in, and I'll try to show that to you in the next few slides. For patients that have a slack wrist and have capitate involvement, where traditional PRCs were precluded, this is an excellent treatment option. Remember, traditional PRCs are indicated for slack wrist where the capitate is not involved, or for snack wrist where the capitate is not involved, where this can be used in those issues. Failed proximal carpectomies, when you go down here to additional indications. I'm seeing several of my patients that come back 15, 20 years later and have been fairly happy with the PRC, although not completely happy. Now have worn down capitate, and this is a great operation for them to obtain some carpal height and get a better fit on an arthritic joint. As I said earlier, that it's also commonly used for failed four-corner fusions. Some of these four-corner fusions have had screws placed into the capitate or have had cartilage removed from the capitate, where this capitate resurfacing is an excellent option. And I think that you're ultimately going to be very happy with it. Technically much simpler than intercarpal fusion, maintain carpal height, improve congruence of the lunate fossa, I think are real true advantages that you'll notice. If you have a patient scheduled for a salvage procedure and you're not sure whether the capitate's involved, you don't necessarily now have to go to a four-quadrant fusion. You can go to this procedure, which is a capitate resurfacing. It's a simpler operation. I think it'll prove to be a lower complication rate than a four-quadrant fusion, and I think that you're going to be happy with it. I think the surgical technique is fairly straightforward. I use a dorsal longitudinal incision, which we're all familiar with our dorsal wrist procedures. A PR endorectomy is optional. Some of us believe that it's a good idea, and some of us don't. I think I'll leave that up to your discretion. You can either use a dorsal capsular ligament sparing incision, as described by Berger and Bishop, or you can use an inverted T incision which probably gets somewhat better exposure, but has the downside of going through some of the dorsal ligaments. I think a radial styloidectomy is something that needs to be looked at intraoperatively. Most of these patients, the trapezium is volar to the radial styloid, so it's not necessary to perform a radial styloidectomy, but certainly if you're in one of those strange occasions where it's present, it can be performed as long as you preserve the radioscaphocapitate ligament. Those all-important volar ligaments, especially on the radial side, are still important to be maintained, whether you're doing a proximal corpectomy or doing a PRC plus. You still want to maintain those volar ligaments when you're taking the bones, removing the bones. There's a variety of ways to move the bones. You can either do it by piecemeal fashion, preserving the ligaments. You can do threaded Steinman pins and sort of take them out with curved knives. I've even used taps from the small fragment set and used that as a joystick. So I'll leave that up to your discretion. This is what it looks like on the left when it's volarly flexed with the proximal row removed. There's an easy look at the lunate fossa on the capitate after everything's removed. A guide wire is placed through the capitate, and I think it's very important, this initial step, using your fluoro, to notice that the guide wire is in the middle of the capitate, because everything stems, in terms of the procedure, off of that pin. Because what you're going to do after that is you're going to use a drill over the guide wire, and then you're going to place the screw into position. You're going to over-drill over that screw eventually, and then place your capitate Morse taper. So, pinning, step drill, tap, insert screw. There's a reaming device that goes over the screw. You get your measuring devices out to look at the lunate fossa and both the AP and lateral plane. There are trials to put immediately over the screw, and then once you see that is fitting the way you want in all planes, these are very stable. You can get flexion to 60, 70 degrees of flexion extension and it will not come out of the joint. You then remove your trial and impact your final implant and confirm placement fluoroscopically.
Hey, Dr. Culp, can you hear me?
Yes, I can.
Yeah, one of the questions was how much time does putting the implant add to doing the PRC overall?
Well, I have one of the questions that's been asked is how much extra time does it take in addition to what would it take to perform a proximal corpectomy? And I can tell you that it probably adds 15 minutes or less. This is not a hard procedure. There's very little fluoroscopy that's required, and once you get your pin in the middle of the capitate, and as I've stated in this slide, it does not need to go into the third metacarpal. It needs to go in the middle of the capitate. It's a 10 to 15 minute procedure. It's not long at all. Right. I have a film somewhere online that is live. It's real time, and you'll see that this is not a long procedure at all. It's very simple. Yeah. Get your post-operative X-rays, pace at a splint. I usually leave the shorearm splint and slight dorsiflexion or extension for about 7 to 10 days. You can either place a splinter cast for an additional 3 weeks. I've been contemplating whether to move them earlier because I think you probably can because they're so stable. But anyway, most of us are starting at a range of motion at 4 weeks. Begin a strengthening at a later date, weight bearing at 3 months, and all activities at 6 months. I have people playing golf with these implants and have had really no issues in terms of complaints. So there's the postoperative regimen, postoperative protocol. What should reps be showing you when you're deciding whether this is something that you want to be involved in? Well, they should first show you an image of what PRC Plus is, why it's unique, why it's different than anything else on the market. They should show you a sawbone model so you can actually look at it and see exactly how it works. there's an expert opinion paper out there that several of us have written that you can look at and critique and add any beneficial thoughts that you might be concerned about, and ask them to show you some pre and post operative X-rays. We're getting up to about a year and a half, I believe, with some of these. Pretty soon we're going to be up to 2 years, and of course we're going to publish this when we hit that 2-year period. But I see no evidence of loosening at this point. Very happy patients. Simple procedure. What should reps be saying, and what do hand surgeons want to know? What is the longevity and durability? As I stated earlier, I'm not sure yet in the wrist. I can just tell you about a year and a half that I've had no issues. But this implant has been used in other areas of the body. That's been used in the great toe with 88% implant survivorship at 5 years. And that's a difficult joint to maintain survivorship in because there's a lot of forces on it. So not the same joint, but a lot of force at that joint, and something that you can sort of translate into the capitate PRC Plus. I'm going to thank you. I think I'm going to stop there. Hopefully that'll demonstrate some of the basics of this procedure for you, and I'm going to open up if there's any questions for the attendees at this time.
Well, one of the questions that just came through is for surgeons that obviously do a lot of four-corner fusions, is there a patient that you think that this might be a better option than just doing a four-corner fusion?
One of the questions that has come up is there a patient that I would think of that would be better to perform the PRC Plus than a four-quadrant fusion? I think that the younger patient, if you got somebody in their 20s that is going to have a procedure done for a slack or snack wrist, I'd probably lean to a four-quadrant fusion. I think as the patient gets older and there's capitate involvement, I would lean obviously to this patient, this procedure. But that number for me is moving progressively lower. I've been so happy with this procedure in terms of its simplicity that my age is moving younger and younger.
Okay. The other thing was there's some people that have been doing oats for younger patients. And is that kind of an age dependent, or is it dependent on the type of disease or the amount of disease?
Yep. The question asked is in my algorithm, my treatment algorithm, is there a role for the oats procedure for capitate involvement in slack and snack wrist? Well, if any of you followed what I do research-wise, I've done a lot of research in oats for PRC, and for a real young patient, that is certainly an option. I would probably steer against an oats procedure in a patient that was older. One of the reasons is that it's difficult to get some cartilage from some of these patients, whether you get it from the knee or from somewhere else on the proximal row. So I think that this procedure, PRC Plus, would again be more likely performed on an older patient where there's less likely good cartilage available to place an oats plug in a capitate, whether it be from the knee or the proximal row.
All right, and then do you ever have patients complain that they're feeling overstuffed by having the implant in versus your standard PRC procedures?
Yeah, one of the questions that has been asked, which is a very good question, is do any of the patients feel as though that their wrist is, in quotations, overstuffed? Almost similar to a radial head implant would be overstuffed. I have not had that issue. If you look at the X-rays, you'll notice that although the capitate Plus does provide increased carpal height, it's not exactly the same as your normal carpal height, and therefore I think that the issue of overstuffing is less of a problem than you would think. Most of these patients, quite frankly, at 4 weeks when they start moving, they say they have very little pain at all.
Right. Good. One more question was about smokers or diabetics or people who historically, have issues with the plates and screws, with the hubcap procedure. Um, you know, is there, is that an option as well, or is it going to be the same problem in terms of fixation?
Yeah, no, very good question asked. Is there an issue with patients that have poor blood flow, poor blood supply, whether it be smokers, patients that you would have some concerns about with, for example, performing a four-quadrant fusion because of the increased non-union rate? I have not seen any issues with this implant in terms of ingrowth for smokers. I think this is a much better operation, for example, for a patient that is a smoker that you would be sort of debating whether a four-quadrant fusion or a PRC Plus would be the correct way to go. I'd be much more likely to perform this procedure than a four-quadrant fusion at this point in time, whether it be diabetics or whether it be a smoker.
Okay, good. All right, and then I think that's it now. The only last question is, have you ever used this in Keenbox?
With the question, if I've ever used it in Keenbox, and the answer is yes, I have. I used it in a patient who had stage 4 Keenbox, where there was really no chance of reconstruction, whether it be an unloading procedure or a vascularized graft. And so I performed this on the patient with Keenbox stage 4, and I was extremely happy with it.
That's great. And then I guess this will probably be the last one. In terms of motion, PRC versus PRC plus, what do you see as a difference? Is there any advantage, or do they have a larger range of motion, when you put the implant in?
The question was a comparison of range of motion of PRC versus PRC plus. You're going to see right away that there's better motion with the PRC plus than a regular PRC. The reason being is that your implant is directly measured to the lunate fossa. So instead of having impingement issues of the capitate on the fossa with a regular PRC, you don't have those issues because of the better spacing, if you will, congruency of the PRC plus to the lunate and the better carpal height.
Right. Great. Cool. All right. Well, thanks again. I really appreciate it. I appreciate everybody getting on. I know it's it's a Tuesday evening and everybody's got things to do. But we thank Dr. Culp for taking his time. If you have any other questions or want to follow up with him on anything else, just send me an email, and I'll shoot that to Dr. Culp, and we'll get that back to you guys. All right. So thanks again for everybody. Have a good evening and happy spring.